Dr. Harry Hausler is the CEO of TB HIV Care in South Africa. He's a family physician, an HIV clinician, and a preventive medicine specialist with 25 years of international public health experience. And he's going to talk to us about the perspectives from a community-based organization, the scale-up of integrated TB and HIV services. Peter.
Good afternoon, everybody, and thank you very much to the organizers for inviting me to talk in this important symposium. And I must say it's a great pleasure to see all of the increased attention and interest in TB preventive therapy. I came to South Africa in 1996 to help with a review of the HIV program and then stayed on as a TB HIV advisor. And we started TB HIV pilot district. So actually we started IPT in 1999 and in South Africa, but it took a long time to really take off. And now, as we've heard earlier today, 39% of people on TPT globally are in South Africa. I'm going to be talking about the right to TB preventive therapy. So I'm taking a human rights and an ethics approach to considering the issues around access to TPT for different populations. So just a quick reminder of what the principles of medical ethics are. The beneficence is that the healthcare professional must do what's best for the patient. Non-maleficence is to do no harm. Respect for autonomy is to ensure that patients have the choice and are well informed to make reasoned, informed choices. And justice is around distributing benefits and risks and costs fairly. So the first ethical issue, use what works, or evidence-based practice. It's clear that TPT works. Isoniazid preventive therapy decreases TB incidence amongst people living with HIV by between a third and two-thirds. IPT provides additional benefit to antiretroviral treatment, as we've seen in Temprano and Lele Rangaka's study in Kailicha. Currently, there are a number of recommended regimens that Dick Chason very eloquently outlined for us this morning, including the most prevalent one that's been around the longest is INH for 6 months. But rifampicin and INH for 3 months has actually been part of one of the options for I think over 10 years. And rifampicin is the new kid on the block and very exciting for weekly dosing with INH for 3 months, as well as the 2 new regimens that are being considered or were considered last week and hopefully will be soon integrated into updated guidelines for one month of daily rifampicin and INH or 4 months of rifampicin. The second issue is do no harm, non-maleficence. And I think we do have to consider that TB is not a nice disease to have. So failing to prevent TB means the risk of a stigmatizing, life-threatening illness with drugs that have toxicities and loss of quality of life. And the increased cost for individuals having to get to health facilities and miss their work and come to the health system is something that we have to consider. So we should be preventing TB to prevent harm. TPT regimens that are currently available have very limited toxicity. 3HP has the advantage of less hepatotoxicity and has better adherence than 6 months of INH. Co-administration of 3HP with dolutegravir-based regimens is really quite important for South Africa. South Africa has 4.4 million people on antiretroviral treatment. It's the largest number of people on antiretroviral treatment of any country in the world, out of an estimated 7.9 million people living with HIV. So interesting, considering the last speaker's discussion about decentralized antiretroviral treatment models, we do have a huge pool of people who could potentially benefit from TPT who are already on ART in South Africa. The estimate is between January 2018, the president actually made a commitment that by December 2020, an additional 2 million people would be initiated on ART. So that's another big potential pool of people who could benefit from TPT. And in August or September of this year, at dolutegravir containing regimen will be the first-line regimen. So it is quite important to ensure that it will be safe to co-initiate ART with 3HP, and studies are underway that Orm Institute is involved in that, Gavin's group, to look at co-initiation. The ethical issue number 3 is, what would I want if I put my shoes put myself in the shoes of the patient who I'm caring for? So if I were living with HIV in South Africa, I would not want to get sick with TB. So I'd want immediate ART, of course, good infection control. I would want to have as many protections against getting infected as possible, regular TB screening, and I would want TPT to treat my latent TB infection, also to potentially prevent reinfection if I was asymptomatic. And I would want to have the choice of what regimen to take. And I would want those choices to be affordable and easily accessible. So that includes 3HP, and for children, 3HR. And then the fourth ethical issue to consider, and this is the one that I'm going to spend much more time on, because TB HIV Care is an NGO that has multiple funding sources, including CDC, PEPFAR, and Global Fund, and other, and provincial and national government funding. But one of the things that we really try to do is to reach the hardest to reach. So we do have, we're a district support partner through PEPFAR in the Eastern Cape, and I'll share some of that data. But we also are quite involved in providing mobile outreach services for sex workers, and providing support to the Department of Correctional Services to improve TB and HIV prevention and care. TPT, in terms of access and justice, TPT is cost effective, it's easy to implement. Testing for latent TB infection, fortunately, is no longer a barrier because it's no longer required. TPT is currently not provided, unfortunately, in many facilities. Its access is very limited for key populations, and this is unjust. So the same accessibility for the general population should be available for those most key and vulnerable in our population, in our countries. And the high price and no fixed dose combination formulation and registration of that formulation by the regulatory authority in South Africa definitely limits access to 3HP in South Africa. I'm not going to spend much time on this, but just to sort of think about both the prevention, so HIV positive people who are asymptomatic then should be evaluated for IPT contraindications, should start and complete, and if people are, the treatment cascade is on this side if people are symptomatic. And we do need to think about both, and I really enjoyed the presentation this morning about looking at the cascades from both sides, from all people who are newly enrolled in HIV care, symptomatic going on to treatment and completion, and asymptomatic going on to TPT and TPT completion. And this really, I do want us to pause and just appreciate this. It is quite remarkable. When we did our TB HIV pilot districts through the protest initiative from 1999 to 2002, we started a few thousand people on isoniazid preventive therapy, and then the first IPT guidelines, in fact, in South Africa came around 2000, 2001, where we did require TST screening. But you can see it really took off from around 2008 to almost 500,000 people, with 455,000 people on, this is the most recent data from the National Department of Health, in 2018. So that really is quite a remarkable increase, but unfortunately it has plateaued and we need to see it increase more. Think again, with around, I think it was 250,000 registered cases last year, that if every one of those has 3 household contacts, that's 750,000 household contacts that might benefit. But with 4.4 million people on ART, that's a huge pool of people who may not ever have benefited from TPT. So we have a long way to go. Now, I'm just going to share with you some of the data from TB-HIV Care's supported programs amongst people living with HIV in the general population in the Eastern Cape, where we provide direct clinical care with clinicians for IPT initiation and completion. In inmates, we really provided technical assistance and support to the Department of Correctional Services clinicians, and this data is from two provinces, Eastern Cape, Western Cape, and sex workers. Where we provide peer-led mobile outreach services with HIV screening, HIV testing, TB screening, and linkage to care. We have increasingly started community ART, but it's been hard to get access to ISANIZID for TPT. So this is the general population data and in different 6-month periods, where you can see that actually the proportion of people living with HIV, newly enrolled in care, who initiated ART was quite good, over 90% over the 3 6-month periods. The red bars show the completion, which is very suboptimal. And as Lucy had said, one of the problems is the recording and reporting. So while we have clinical stationery, if clinicians don't fill it out, then it's not considered to be done. So we think actually that there's a much better completion, but it's just not properly recorded. But because of increased then focus in the last 6-month period, October 18 to March 2019, and actually over the last year, in fact, we've shown an increase from below 40% to 60% completion. Again, that needs to be much higher, and we're working with the Department of Health staff to improve that. Now, this is just comparing various key populations. People living with HIV, of course, are a key population on their own for TB, but amongst people living with HIV, or in the HIV communities, sex workers and inmates are also considered key populations in South Africa, and showing that while we've had excellent 100% ART initiation in the general population with 94% IPT, we've only had 64% ART initiation in correctional facilities. Actually better IPT initiation, surprisingly, 76% in these two provinces. And then amongst sex workers, only 74% initiation for ART and 20% TPT. So there are inequities here. Fortunately, in one of our districts, in Kangala district, we've been able to achieve higher initiation rates because of being able to get the ISANIZID from the Department of Health and co-administering on initiation ART and IPT. There are some of the reasons for the low uptake of IPT amongst sex workers. Some sex workers decline it. It's not a priority for them. If they don't have symptoms or disease, they don't particularly want to be taking a prophylaxis. Clinicians say that substance use is a big concern, and it is amongst sex workers. There's a lot of drug and alcohol use, and some clinicians are concerned of that being a contraindication. Some sites were only to obtain, as I mentioned, approval to access the drug recently as a civil society implementing partner, and we need to have professional nurses on the team to administer both ART and TPT. And in correctional services, again, to point out that 76% initiated. Some reasons for not correctional prisons are a really challenging area because there's a lot of movement between facilities and in and out of prison and with remand detainees who haven't yet been charged and incarcerated. So all of these are challenges. So my conclusions are that access to TPT for people newly diagnosed with HIV is high. In South Africa, we haven't been measuring access to TPT for people who are known positive, who've been on antiretroviral treatment for some time. And we do need to start collecting that. And then access to TPT in other key populations living with HIV, in the two examples that I showed, but also amongst transgender and people who use drugs, we also provide services to them. It's really suboptimal. I've got 2 slides of recommendations and one on advocacy issues to take up. Around beneficence, the recommendation is that TPT works. And all people living with HIV and key populations for HIV have the right to TPT with ART and adherence support. And the adherence support is quite crucial to ensure that they get the maximum benefit and complete their treatment. Non-maleficence, TPT is safe, and drug safety monitoring should be integrated in care, particularly if we're going to be rolling out 3HP with ART initiation. Autonomy, we have to give people choices. Tell them what are the risks and benefits of both, and or of the available regimens, rather, and allow them the choice and ensure that there's access. And yeah, the recommendations around justice and access are that people living with HIV who are asymptomatic have the right to TPT with integrated ART. Access to TPT should be scaled up along with increased access to ART. We need to do a better job of both. And we need to do more for those who need more and leave no one behind. We need the cost of rifampicin to be decreased, and it needs to be more accessible, and we need to ensure access to all regimens. So the key advocacy issues in my mind, and TB/HIV Care is working with a whole group of other civil society organizations on advocacy around TB and support for advocacy amongst parliamentarians. And the prevention is very high on the agenda. So we need to accelerate implementation of the new TBD guidelines that South Africa is now finalizing and to include the new regimens, decrease the price of rifampicin, and put pressure on the pharmaceutical, the companies that have the drug to scale up production and decrease the cost. We need to rapidly register fixed-dose combination formulations with rifampicin and isoniazid, and provide treatment literacy so that we do, while we're increasing supply, we also increase demand. And we need that literacy to be done not just amongst people living with HIV, but also amongst household contacts. We need to strengthen the monitoring and evaluation so that there's more attention on it, that people are held accountable, and include TPT in our country multi-sectoral accountability framework. And that's something that South Africa has yet to complete, although through our South African National AIDS Council, we do have monitoring of our national strategic plan. One of the recommendations of the UN high-level meeting last year was that there should be, every country should have a multi-sectoral accountability framework, and that is a mechanism to hold all parties accountable, both government, private sector, and civil society organizations, to reach the targets that have been set. Those are my contact details, and just to finally say that health is a human right and access to TPT is a human right. Thank you.